Okay, we are recording. Let's share the screen. Um, Share. Okay, here we are. Now, hello everyone. My name is Nicholas Abate. I today will be presenting on the use of end-tidal capnography to monitor non-intubated patients presenting with acute asthma exacerbation in the ED. Now, what I want to talk about is essentially what is capnography, a little bit about asthma, the intersection of the two, and then how it's implemented in the ED. And we want to go down. Okay. So what is capnography? Essentially is the measurement of CO2 throughout the breathing cycle. It's going to usually be on a monitor. It's going to display a measurement with numbers and a graph, we call it a capnogram, of CO2 levels over time. And it can give us information on ventilation, essentially the effectiveness of CO2 elimination, ventilation, essentially the transport of CO2 in vasculature, and lastly, metabolism. It can give us an idea of the production of CO2 via cellular metabolism. Today, capnography is used largely in anesthesia as end-tidal CO2, but it's also used, for example, in the emergency department during intubations, for example. We could use it to determine whether intubation has been done properly and it's in the trachea and the lungs. And we could use it to rule out the fact that we may have intubated the esophagus. You could determine whether you've done an esophagus intubation via capnography as well. Now, the development of it basically started in World War II. It was used to measure CO2 levels in submarines. I found that kind of interesting, actually. In the 50s, it was used experimentally in anesthesia to measure expired CO2, and it wasn't implemented actually until the 80s that it became widely used, mainly in anesthesia use. Now, let's talk about a capnogram. Here we see a capnogram. I think you could see my mouse. So the yellow phase is the expiratory phase, and the blue phase is the inspiratory phase. Let's talk about the inspiratory phase first because it's quick. Phase 0, it's your inspiratory phase. Essentially, it's your breath out. No, it's your breath in, where your CO2 drops to 0. So essentially, and as you take in oxygen, your CO2 is dropping to 0. Now, your expiratory phase, phase 0, starts with this flat-ish part of the curve here. Essentially, that is expiration of anatomical dead space. It doesn't have much CO2 in it. And then you move on to phase 2, which is rapid expiration of CO2. It goes to about here and moves on to phase 3. Between phase 2 and phase 3 is your alpha angle or your Q angle, again, located between phase 2 and 3. It's normally about 100 degrees, and its height, I did read, is related to cardiac output. Now, phase 3 is when towards end expiration, and that's when CO2 reaches almost steady state levels. And here's your EtCo2 point. It's the very end of your expiration phase. And this number of CO2 is the concentration of CO2 here, right at this peak. And that approximates the concentration of CO2 in the alveoli. And lastly, it's not shown on this graph actually, but this between phase 3 and phase 0, this angle right here is your beta angle, and that's normally about 90 degrees. So let's talk a little bit about asthma, right? What is asthma? It's an episodic bronchospasm with inflammatory infiltrates and mucus plugging, and it's related to allergen exposure. While bronchospasm and collapse of small airways leads to differential increases in CO2 in different pulmonary territories, right? So what does that mean? Well, a collapse of an airway, for example, in one region of a lung is going to cause vasoconstriction of the vessels in that lung, and essentially shunting of blood to another area of lung where it can get properly perfused. This causes a VQ mismatch in the area of the lung that is collapsed and leads to accumulation of CO2 behind that collapse. Now, on expiration, you're going to get expired CO2 from the areas of the lung that are not collapsed or restricted, and so that CO2 is going to move out normally. However, there's another part of the lung where it's collapsed. So you're not going to get expiration of anything. So essentially, that expired CO2 is going to mix with dead space, okay? And that's what's going to be expired, and that's going to show up on capnogram. And I found that to be important because what I thought when I first started this, and I've come to learn that this is not the case. What I thought actually was I thought about asthma. Okay, allergen, bronchospasm. We're going to get decreased expiration, so accumulation of CO2. So we must get increased EtCO2 on our capnogram. And that, in fact, is not the case. We could see here that this is the black line is a trace of a regular capnogram, and the purple or pink line is a trace of capnogram in asthma. And there are a few distinct changes. We're going to get a little bit of a decrease in the slope of phase 2 here. We're going to get loss or softening of the angle of the alpha angle, also called the Q angle, and we're going to get an increase of the slope in phase 3 here. And that's essentially what we're going to see on capnogram of asthma. Now, let's talk about how we're using capnogram in the ED in regards to asthma. So essentially someone comes in, there's a couple studies done 10 years apart, and they conducted studies on patients presenting with acute exacerbation of asthma. And both of these studies, Ho et al. 2008 and Truchat et al. 2018, both actually found no significant differences between your EtCO2 values pre and post treatment. Now, this is important because physicians are going to interpret this as what? As, okay, it's not useful for me to use capnography in acute asthma exacerbation because it's not telling me anything, essentially. They also found so that was a similarity between the two studies 10 years apart. There's also a discrepancy. Ho et al. 2008, they found a significant decrease in the Q angle or the alpha angle that I was talking about post-treatment. However, Truchat et al. Found no significant difference in the Q angle. Now, the capnography measurements were actually a bit different in the cases, which I think explains this discrepancy. Ho et al. Actually did capnography when the patient was cleared for discharge. So they've been treated, they're ready to go home. Truchat et al. Did capnography at time 0 and time 60 minutes. So that's probably the discrepancy in the Q angle that both of these studies showed. Now, currently, right, the use of capnography in asthma is actually unclear. This team, Corbo et al. 2005, they showed that EtCO2 from capnography about approximates PaCO2 from ABG. And they concluded that EtCO2 is a viable substitute for needle stick in ABG in the acute setting. So they're saying that you can use capnography to determine your EtCO2 and essentially your PaCO2 in acute asthma exacerbations. Whereas this other team, 5 years later, Delermy et al. 2010, they essentially studied the same thing. And they showed something similar. Yes, EtCO2 and PCO2 is about approximated, R value of 0.82, so a decent correlation. However, 38% of their participants had a discrepancy between the two measurements of EtCO2 and PaCO2 that was greater than 10 millimeters of mercury. And they concluded that EtCO2 does not seem to accurately predict PaCO2. So a variety of studies over the past 15 years have showed unclear results in terms of acute capnography use in asthma exacerbations. So what about the future of an alternative? So I was reading actually an interesting paper on the implementation of computer algorithms into capnography monitors. So the monitor you're looking at is showing your numbers and your capnogram. They were talking about writing an algorithm and programming it into that monitor so that essentially it's going to recognize an asthma capnogram and alert the provider that this patient is presenting with an asthma capnogram. So that's an interesting futuristic kind of little take on it. But essentially right now, the gold standard for an asthma exacerbation in the ED, because essentially I wanted to talk about, okay, if not this in capnography, then what? Well, the what is peak expiratory flow rate. That's the current gold standard currently. It can give an indicator of airway obstruction. It's simple to use. It's non-invasive. It's non-expensive. It can help estimate the severity of acute asthma in the ED, as well as help to monitor treatment response. It does have some limitations in that you need patient cooperation. You need a little bit of patient education. And also that Truchat et al. Study, they found that PEFR actually is only performed correctly in 47% of cases. So it's not perfect, but it is the current gold standard. Additionally, you can use, you're going to repeat this PEFR at 1 hour and that's your best predictor of hospitalization in patients with acute asthma. Now, I wanted to go through a little bit of a clinical adaptation as to what you would do if a patient came in with acute asthma today to the ED. So essentially, they're going to come in probably in respiratory distress. You're going to do a quick assessment of physical, and you're going to probably notice that they're in respiratory distress. So you're going to want to do a PEFR. And essentially, based on that PEFR, it's going to give you a percentage and drop them into a category. And based on that category, whether it be moderate or severe exacerbation of their asthma, is going to determine your treatment. Largely, we're going to give short-acting beta agonist and tiotropium. And from there, you're just going to monitor response. Are they responding well? Are they not responding well? And it's going to be a little bit varied, but you're going to go from there. Now, if they're depending on whether they're responding well, not responding well, that's going to guide what's going to happen with the patient. So whether they're going to be admitted, whether they're going to go home, whether they're going to go to the ICU, and treatment is going to go from there. So in all, right now, capnography in acute asthma exacerbations, not intubated patients, is not the gold standard of treatment. The data is showing that there's no significant usage, but there could be ongoing studies currently that I haven't found actually. But that is where the field is at with capnography. And here are my references. And that is my presentation. Thank you for listening. I'm going to stop the share and pause the recording. All right.